We just talked a whole bunch about people who have reduced D2 receptor, D2 dopamine receptors. And I didn't mention this before, but what this is referred to frequently is dopamine deficiency. The idea being either you don't have enough dopamine hitting those receptors or you don't have enough receptors, which leads to that state of compulsive use despite consequences. So people who have dopamine deficiency has been shown to be one of the most common predictors of risk for addiction, one of the strongest factors that related to it. So the question would be, how, besides being exposed to drugs of abuse, junk food, or injury, would one wind up with reduced D2 receptor? What else puts you at risk? So one of those things is there's actually a genetic polymorphism, so there's variation in people's genes. The A1 allele of the D2 dopamine receptor, it doesn't change the receptor at all, but what it does is it changes the rate at which, or how much of that D2 receptor gets expressed. So people who have that A1 allele of the D2 dopamine receptor make less D2 dopamine receptor. They have less on the surface of each of their cells in any given context. And having that A1 allele has been associated with having increased risk of substance use, increased risk of obesity, increased risk of post-traumatic stress disorder, which you could think of to some extent as compulsive anxiety despite consequences. And it's also associated with persistence of those, so greater difficulty getting better or stopping substance use or losing weight or such after you start. So one way you could wind up here, you could just be unlucky enough to have that polymorphism. Other interesting part, there's studies, so low social status, which I think of as kind of a chronic state of lack of reward opportunities potentially, has been associated with low D2 receptors. And I'm just going to tell you really quickly about a study because I think it helps illustrate just how fluid these D2 dopamine receptors are. This is not a static function or something you can't change. So in this study, they took macaques which are very social, just like humans, and they put them in solitary cages. So they were all alone by themselves, didn't have anything to really make their lives better. And they took them out and after 3 months, and they looked at their D2 dopamine receptor levels, and they found that consistently all of them had incredibly low D2 receptor levels. They then took them and they co-housed them and let them live together for 3 months while they observed their behavior. And they tracked social hierarchy amongst the monkeys, looking essentially for things like when they gave the group food, who got first access to food, who groomed each other, which are the monkeys that got all the benefits of being in a social group versus the ones that didn't. And then they took them back and they PET scanned them all again to see what their D2 dopamine receptor levels look like. And what they found was that the monkeys that were at the bottom of the hierarchy looked exactly the same as they did when they were socially housed. They had low D2 dopamine receptors. The monkeys that were at the top of the hierarchy, who benefited from being in a big social group, had massively upregulated their D2 dopamine receptors. And the really interesting part about this was they had given them exposure to cocaine just to see what they would do in that first when they were isolated. And every single one of those monkeys would spend every last minute that they had, that they were given access to cocaine, taking cocaine. After they co-housed them, only the monkeys with a low D2 dopamine receptor, only the ones at the bottom of the hierarchy, continued to take the cocaine. The rest took it for a little while, very rapidly got bored with it. So not only does the D2 receptor change substantially, if you can increase reward opportunities in your environment, your D2 dopamine receptors levels will come back. There's likely some feed-forward loop as well that gets those expressed more. Nobody's worked that out exactly, but I don't see how else you get that sort of response. And having those D2 dopamine receptors changes whether those behaviors stay compulsive, even things like cocaine taking in a pack of monkeys who, you wouldn't think they'd have a lot better to do, but apparently it's more interesting to get have fun with your peers than use cocaine if you've got enough D2 to stop yourself from doing that. So just key aspects of that. Other things that put you at risk for addiction. Well, interestingly, the strongest predictor of addiction to prescription opiates is a duration and dose of exposure. So the more time you have to learn relief-seeking habits, the more likely it is that you're going to become addicted to your prescription opiates. The other piece that points out is, yes, there are a whole bunch of genetic and social and other risk factors, but exposure is still a huge contributor. Anyone can learn these things if they're trained long enough. The differences are sort of how quickly and how fast do these behaviors get trained in and become compulsive. Obviously, problems with impulsivity also predict risk for addiction. So things like ADHD, impulse control disorders, anger problems, things like that are risk factors for developing prescription opiate addiction. One other kind of cluster of risk factors that we see frequently are history of abuse, trauma, shows up in all sorts of prediction screeners, and post-traumatic stress disorder. It's been shown it's a known risk factor for substance use disorders of all sorts, as well as development of chronic pain and obesity. So all sorts of things where you've got kind of chronic compulsive use behaviors. So why is that the case? So we actually, again, there's pretty good research that tells us why PTSD patients are more likely to have trouble with these compulsive use despite consequences kinds of disorders. Essentially, one of the key findings, if you look across studies of PTSD, you find that patients with PTSD don't turn on a part of your frontal cortex called the ventral medial prefrontal cortex. It's right here during stress. And there's been some really interesting rodent studies that look at, what the heck does this part of your brain do? And what they find is that depending on what your exposure to stressors, if you have control over a stressor, right? So and they show this essentially. So if you shock a rat, but they have the ability to do some work to turn off the shocker, versus if you shock a rat and he doesn't have control over it, right? You can shock him the exact same number of times, so you can match it. So this one who has control, the one that doesn't have control, basically gets the same shocks that the other one has. So no difference in the stress that they've experienced, except that one can turn it off. What you find is that the one that can turn it off doesn't develop all sorts of stress-related problems, doesn't develop anxiety disorders, doesn't develop a whole variety of behaviors that you might expect somebody traumatized to develop. And that rat that couldn't control it does show. And those rodents that have control turn on their ventral medial prefrontal cortex during the times of those stressors. The ventral medial prefrontal cortex, it turns out, talks to a part of your brain that contains serotonin neurons, your dorsal raphe nucleus. That part of and it shuts it off, essentially. Your dorsal raphe nucleus sends serotonin through systems as part of a stress reaction. One of the things that it does is it talks to your VTA dopamine neurons in that same pathway, and it acts kind of like a multiplier on those reward opportunity amounts. So whenever the dorsal raphe nucleus is activated, any reward is twice as good. It's twice as good of an opportunity. It's just like adding that dopamine reuptake inhibitor into the circuit. You've now basically amplified the reward value of any potential reinforcer. What that means is that, which again makes you more prone to develop things like substance. You're going to reward seek, you're going to relief seek because those just you're going to eat the junk food because those just rewards come out as being more important. Your brain is oriented to those quick relief seeking components. So essentially what you find, exposure to stress that you can't control seems to actually shut down the ability to turn on this, to activate this part of the brain. So you can do experiments once you've exposed an animal to an uncontrollable stressor. They have trouble learning that they can control other stresses in the future. And you get the opposite thing if you take a rat that has been trained that they can control a stressor, and then you expose them to something that they don't have as much control over. They still activate this center even when it's really not that in control. So history and development of trauma and early childhood trauma, and especially and development of PTSD winds up being a strong predictor of developing these habits because these circuits just are primed essentially to learn relief seeking and reward seeking habits.
So what might be
Yeah.
worth in noticing that percentage of people who have that background that don't develop addictive behaviors, because that seems to be pretty key to the others.
Yeah, absolutely. I mean, I would argue it's all the same training piece. The more you can, exposure is still always the most important part. You're going to learn to do the things that you practice. So if you are practicing well behaviors, you've got your life, you're spending your time doing healthful, productive things, right? Like remember, problem solving is just as reinforcing as, candy bars. And if you spend your time and that's what you get into, right, you can wind up being a highly productive, high functioning person, even if you are a little bit compulsive about it. So, you're not doomed, but you're at risk. You do not want to have exposure to things like, full access to junk food all the time or chronic pain or things like that, or you're at greater risk of developing bad patterns. I've mentioned this before, but using to cope is a risk factor for development of addiction across disorders. Again, it's, learning to drug seek in response to negative affect is a problem because excessive drug use leads to negative affect, and you're going to wind up with this feed-forward system. And people prone to negative affect are also more likely to develop addiction. So you have increased risk with depression, bipolar, and other mood disorders as well. So generally other thing to worry about. But just quick take-homes here. I would just say all patients exposed to opiate analgesics are at risk of developing addiction. I know we work a lot with Congress in my current job, and right now they're very interested in opiate addiction. There are 18 bills that they're working on right now. In them, some of them really, really helpful, some of them a little bit misguided. But one of the things, for example, that they were going to insist that we implement at VA was a big flashing red sign on the front of our medical record that said, risk of addiction, basically, for anybody who is at risk of addiction. And we keep trying to tell them that the biggest predictor is just being exposed to anything. What are we going to do? Put risk of addiction on anyone who's ever had an opiate, a stimulant, a benzo, or whatever? I mean, it might as well just stick it on every medical record. Anyway, point being, everybody exposed has some risk. So you gotta monitor. You can't just say, oh, you seem fine, I'm not even going to check. You need to pay attention to function and declining function in all your patients. History of trauma or family addiction, family history of addiction, all as other big risk factors, mood disorders, and problems with impulse control. All of these should make you not necessarily take pause in trying to treat patients, but be very careful. These are people you want to increase monitoring on. These are people you want to bring in specialists. You don't leave their mood disorders untreated while you go treat their pain with opiate analgesics. You make sure you get them into care for the other the other things. If they've got, a history of addiction and you're going to start them on an opiate med, you make sure that they're engaged with some recovery network so that they have some support, because people wind up having trouble even if not. So these are risk factors that you should make sure, patients are getting extra care and extra monitoring when those are in place. Okay, so I'm going to switch gears and talk about overdose prevention and treatment. So we mentioned already, opiates cause respiratory depression and sedation. These are quite obviously dose-dependent effects. These are pharmacological effects. They're additive in combination with other sedatives. So if you add in benzodiazepines on top of opiates, on top of antidepressants, on top of some anticonvulsants, which, not uncommon in complex pain patients, all of those combined are going to make things harder. If the patient goes home and decides he's going to drink alcohol on top of all the medications you just had, you're in deeper doo-doo, right? So when you're thinking about your opiate dose, you got to think about all the other things that they're on as well. You get greater effects, obviously, when they're combined with physical vulnerabilities, so respiratory cardiac problems, metabolic clearance problems. These are all fairly obvious things, but what we tend to find is that people think about everything a little too much in isolation. So when you're considering your patients, you got to kind of look across all of these risk factors to get a sense of, really how much can this patient manage. The complicating factor on this one as well is that tolerance to the respiratory depression effects develops quickly and it fades quickly. So people, if you titrate up a dose, patients can become very, very tolerant to the respiratory depression and the sedation effects of the opiate. But let's just say they stop taking it for 3 days, for a couple of weeks, and then they come back to that dose that they were on before. That tolerance may be gone, and then they're at substantial risk of overdose at that point. So I'm going to talk quickly. There's a couple of different types of tolerance that have different implications for when you need to worry about people having overdose due to tolerance. So first is kind of exposure-based tolerance. This is very, very similar to dependence. In a lot of the mechanisms are identical, essentially. So in some cases, they're one and the same. Idea here is your brain's going to get used to having the drug on board. It's going to change the sensitivity of your circuits so that signaling is normal when the drug's on board. So the way I think about this, if you are in a bright room and you shut off the lights, right, for a little bit while, you can't see anything, but pretty quickly, your eyes adapt and you can see just fine. And then if you turn the lights back on really quick, you're going to be blinded for a while and then they'll adjust again. It's the exact same type of processes. I will say the brain is so focused on adapting. It's got so many different ways that it does this. There's like receptor mechanisms, cellular mechanisms, circuit mechanisms. There's so many different ways that your brain tries to adapt that I'm not even going to try to go through them. Just promise you that they adjust in a ton of different ways to make you as normal as possible in what is your normal environment at a given time. This same process has been associated with what's called opiate-induced hyperalgesia. The idea here is that this is a state where your brain has adapted to having analgesics on board, essentially. So you put on a bunch of analgesics, you damped down the pain circuit so it's harder to send signals through them. So what your brain said is, well, I had those circuits there for a reason. I want to hear what's going on. And so what it does is it increases the sensitivity of your pain circuits so that it can hear through the damper that you put on it. What that can do is basically, if you then take that opiate away, you're going to have massively sensitized pain circuits, which can cause pain just from the increased sensitivity together. So And again, the only way to get rid of that essentially is to take off the opiate slowly, and then the circuits will readjust themselves because they don't want to be screaming at your brain any more than they want to be whispering. They want to be sending signals at a normal level. So they'll readjust themselves back to normal state once you take the opiate off. But sorry. But in the meantime,